My name is Justin Hicklin, and I'm a PGY2 at OSU Internal Medicine. Today, I'll be presenting our QI project, Improving Recognition and Diagnostic Timeliness of Hemophagocytic Lymphohistiocytosis at OSU Medical Center. You'll see my name, Alyssa Wynn, Anna Kaiser, who are our medical students that assisted, and then our faculty advisor, Dr. Anderson. So just to briefly touch on HLH. So HLH is an inflammatory response syndrome. That's really hard to diagnose. There's non-specific symptoms. There's not one specific lab or imaging test that we can test and say, yes, this is HLH. So the point of this project was actually we had a case of kind of delayed diagnosis with a poor outcome, and we wanted to look at prior cases to see, has this happened before? Is this a problem with how we work up HLH, or is this just kind of the nature of the disease? And you can kind of read a little bit more about that in the background section as well. The big key takeaways, I think, are two things. One, you have to have a high clinical suspicion, and this is going off of figure 1, when you see a super elevated ferritin with these nonspecific sepsis-like symptoms. And that ferritin is greater than 6,000, and that's calculated from the H score. So this H score is kind of how you can risk stratify these patients. It gives you a percentage or chance of HLH, and that's talked about in that little blurb with our caricature. So calculating that early is key, but then the second step is that number 3, or I should say the third step is the important part, which is starting the workup for HLH early, and that's ordering that soluble IL-2, trending the ferritin, and obtaining a bone marrow biopsy. The reason it's important to obtain that early and possibly before oncology consult is because these tests take days to come back. So if the patient is, we're waiting for confirmation of HLH, the earlier we get that testing done, the better, because we're not just waiting on lab delays to tell us. So the key results that I want to touch on here, you can kind of see, in table 1, this is our table-based data, and then figure 2 is our timeline. So they both kind of have similar data, but we had 5 overall patients since 2021 that had a diagnosis of HLH listed in their problem list. Most of these cases were HIV associated. Most were associated with disseminated histoplasmosis. The key things to take away, so you can kind of see in table 1 if you want to follow along with me, some of these cases we were right on it with ordering a ferritin, but then there was a little bit delay between getting the bone marrow biopsy, sometimes waiting until day 11, or there was a delay in, or possibly not even ordering that soluble IL-2 receptor. So interesting to look at the prior cases, and important to recognize that when you see that ferritin greater than 60 or 6,000, we should be ordering these workups a lot sooner. There shouldn't be a delay in ordering this soluble IL-2 receptor, which is just a lab test, and we should be getting a bone marrow biopsy as soon as we can. I also included the H scores just for reference because calculating that can tell you the percent risk of HLH. So it's possible that you can have by calculating that score and knowing to calculate that score, a clinical suspicion early. So the figure 2, if you're visual like me, just gives you an idea of these timelines. And again, the takeaway, like in patient 3 and 4, you can see that ferritin was elevated on arrival, greater than 6,000, but yet bone marrow biopsy was delayed. Soluble IL-2 order was not ordered till at least day 5. So it's interesting to kind of look at each of these patients' hospital stays. So what are the big takeaways from this? What's the goal? Obviously, our plan is to implement this order set, an HLH order set, to help residents get to the diagnosis faster, as well as talk about the importance of ordering these tests. We have both those interventions planned for the fall. What do we know about this baseline data? Well, the baseline data shows us that there are some kind of variables to when we work up this disease. We're missing things, and you'll see those outlined in the figure. We've got 2 patients where we didn't order the receptor. We've got 1 with a missed bone marrow biopsy. So that's 3 out of 5 patients where the complete workup wasn't completed. So I think that's where this implementing a order set will help us get to the diagnosis and not miss these steps. Another big thing that we noticed is that the reason that the bone marrow biopsy is often delayed is because it takes, the right personnel. We need the lab there, and we need somebody who's trained to identify spicules. So it's hard to obtain these bone marrow biopsies because, you have to kind of coordinate the right trainee to be at bedside at the right time, and the patient can't be getting any other image, and a lot of these patients are super sick. So it does take some steps to coordinate, but if we're trying to do that from, the immediate moment that we realize the ferritin's high, it's possible we can improve the diagnosis and have better outcomes. So again, kind of next steps are to implement that plan in the fall to look at steps going forward to see if we can improve outcomes in this disease that's very fatal and very quickly progressing. And we'll see what the next set of data shows. So thank you for your time. I really appreciate it.